We're down by operating room 10, 11, and 12, which is where we do just about all of our bariatric surgery. This is operating room 10, which is where we have the Da Vinci robot. We've got the XI in there, which is the most advanced system out right now, and that's what we use for all of our bariatric surgery. And then we've got our traditional laparoscopic rooms, 11 and 12, where we've got all the ceiling-mounted monitors and everything else meant for doing regular traditional laparoscopic surgery, but with all the latest gear. Here we're in an operating room that's not currently set up for any sort of procedure, so you don't have to have your mask on until they open up the sterile equipment. I'm standing right next to the operating table, which can be adjusted in any number of positions. It can go up, down, tip somebody upright if you're reaching into the upper abdomen, so that way their intestines hang to the lower part of their abdomen. If you tip the head down, the intestines will move towards the upper part of the abdomen if you're trying to reach something in the lower belly, such as the rectum, the uterus, the appendix, things like that. You can also tip a little bit side to side if you're working on one side of the abdomen more than the other. And we have all the anesthesia equipment up here. This is a machine that provides the anesthetic, monitors the patient's vital signs, and allows for flow of oxygen and any other gases that the anesthesiologist might be using. Back here, we have a tower mounted from a ceiling boom that allows us to move it around anywhere we need to access the patient and be able to use all of our equipment. You've got your cautery unit on the bottom, which provides different sources of energy that lets us cauterize tissue and divide it without having bleeding. We have a light source which goes to our camera that leads into the abdomen to shine a bright light because the abdomen's a dark place. We have the camera, and we have the source of the carbon dioxide that inflates the patient's abdomen, so that way we can see what we're doing, because normally the abdomen is flat and there's no room to see anything that you're doing, so we inflate it with carbon dioxide, and that allows us to see. The carbon dioxide is used because it's non-flammable when you're using cautery. If you're using pure oxygen, you'd have an explosion. And then it also reabsorbs fairly quickly, unlike some of the other gases you might consider using, which would take a very long time to reabsorb. When you come into the operating room, you might actually hear some music. Some people are a little surprised when they hear a little bit of music, but when you're in here working all day, every day, it helps to kind of keep things a little more interesting, lively. We don't usually turn it up very loud because, of course, we always want to be able to communicate to each other. But if you ask most surgeons, they do have some music playing in the background. Over here we have all sorts of other equipment that might help pad or position a patient appropriately depending on what type of procedure they're having, if they need their arms out, their legs out, in any sort of different position. We've got foam pads because when someone's under a general anesthetic, they can't tell you if something's getting pinched or hurt, so we make sure to pad somebody appropriately so that way they're not going to develop any sort of wound. We've got these SCDs, we call them leg squeezers. And these go on somebody's calves and they squeeze at timed intervals because they're hooked up to a machine that helps prevent blood clots from forming in the legs. If those form in the legs, they can go up to your lungs, and that can be a potentially fatal complication. Very rare, but of course we like to prevent anything from happening.
Here's the hallway that our patients walk down before surgery. We like to have them walk so that way they're as active and moving around up until the last minute before they go into surgery and have a general anesthetic. You can see all the beds sitting out here outside the rooms. That means somebody is in surgery right now. And in between the operating rooms, we've got our scrub sinks here where you can use different types of soaps, either an alcohol-based or use a water-based soap, and wash your hands before surgery to get things nice and clean. It's not actually perfectly sterile. The gloves are sterile, but your hands are as clean as they possibly can be before the surgery.
So here we're looking at the back table, which is where we set up all the equipment when we're actually going to be doing an operation. You got to be totally sterilely gowned if you're going to be anywhere near all of this equipment. So this is me, gown, gloves. I actually wear 2 gloves when I'm operating. It's for extra protection against an accidental needle stick. So come on in and you can see what we've got here. This is a scalpel. This is an 11 blade and is extremely sharp. Those are a single-use item, just the blade at the tip. This is what we use to inflate the abdomen with carbon dioxide when we're beginning the procedure. And then these are a variety of trocars. These are long, skinny instruments, and this little plug comes out, and our instruments go in and out through there, and they are poked into the patient's abdominal wall and allow us to keep an airtight seal with our instruments while we put this sort of thing in and out of the trocar, like that. This is a grasper, which when it's closed will fit through the 5mm trocar, those small ones, but then you can open it up and it'll have a larger range of motion so that we can grasp and handle
the stomach and small bowel and any other tissue inside the abdomen. These are all staple loads. These are a big part of what we use to divide the small intestine and the stomach and then to reattach them to each other. There are different sizes, and they can come with a little reinforcement strip on them, or they can come without the reinforcement strip. The staple load's attached to the staple handle right here. They clip in like that. They can be rotated. We can angle the staple load up and down, and then you pull the trigger to fire it. This is a suturing device, which it doesn't fully function without a needle in it, but it can pass the needle between the two jaws, so you can sew back and forth. Here we're looking at all the different components for the Da Vinci surgical robot. The decision to use this is up to the surgeon, as there isn't any research to show us that it is any better outcomes for patients to use this versus traditional laparoscopy, but it is definitely better to do a procedure laparoscopically or robotically compared to a large open incision. This is the console where the surgeon will be sitting and controlling the robot at all times. Over here is the back table with all the other instruments that will be used during the procedure. Here we're looking at some sutures, some absorbable and some permanent sutures for the patient. And here we're looking at the robot being wheeled in and will be mounted over the patient, and the 3 different arms will be used to control instruments, and the 4th arm is used to hold the camera, and the surgeon is able to control these during the procedure. It then rotates into position to aim at any particular portion of the patient's abdomen where the surgeon will be working, and the camera is aimed at the target anatomy, and the arms will move into position and will then be docked to the trocars that are going into the patient's abdomen. Here we're seeing Dr. Inman working at the console and controlling the robotic arms during a bariatric procedure. Thanks for watching.